All right. I do see folks still filing in, but I want to make sure that I leave us enough time to get to all of the important information that we're going to cover today. So why don't we go ahead and get started? Good morning again. My name is Kyle Sullender. I'm the Director of Economic Policy Research at the New Jersey Business and Industry Association, one of the member organizations of the New Jersey Business Immigration Coalition. And I have the privilege of welcoming you and providing a brief introduction to our very special program this morning. As you may know, NJBIA and the coalition joined together some years ago to sponsor the Garden State Immigration Policy Institute, which has the goal of educating the public on vital public policy questions in the area of immigration. And we do this by marshaling the best research and the best expertise in specific policy areas to the best of our ability. We also believe in the importance of building consensus on policy reforms that span party divisions. So important in today's climate. And before we go any further, I would like to just pause and give a shout out to our two sponsors for this morning's program, who I believe are on your screen right now, the law firm of Maynor and Landis LLP and St. Peter's Healthcare System. Without the support of our sponsors, we simply would not have the capacity to mount programs of this type and of this quality. So thank you again to St. Peter's and Maynor and Landis for making today's event possible. The topic for today's program may be one of the most important that we've addressed yet in these events. We are attempting to understand the connection between immigration and the health and well-being of all Americans. And hopefully we'll do this by addressing questions such as, are the workforce shortages that we're experiencing today in the healthcare sector a temporary phenomenon, or are they chronic and maybe even worsening over time? Or is employment-focused immigration actually the key to maintaining the quality of healthcare in America? We've brought together an impressive group of people as presenters and panel members who will hopefully help us find some answers to these and other important questions. Before I introduce our keynote speaker for this morning, I would like to give you a quick rundown of today's program. After our opening presentation, you will hear from a panel of representatives from 5 New Jersey organizations who are active in the healthcare field. They will share their experiences and perspectives on the issues that we'll be discussing today. This will be focused by a Q&A session, and we'll end the program by listening to the insights of officials from 2 national organizations that have taken the lead in advocating for policy reforms that would enable more immigrants to contribute their talent and labor to the healthcare sector. And before I go on to introducing our keynote speaker, I want to go back 1 second to that Q&A session that'll follow our panel. I want to remind everybody that you can drop your questions in the Q&A box or the Q&A section on your screen, which is separate from the chat section. And I always like to encourage participants, you do not need to wait for the Q&A session to begin to start putting your questions in the Q&A box. If you're like me, you'll have a lot of thoughts and questions throughout the discussion. And if you're really like me, you will forget most of them by the time you actually get to the Q&A. So please feel free to drop them in the Q&A box as you have them during the discussion. And one of our moderators will help to get to those questions as we then move into the Q&A session. With that, it is now my great privilege to introduce the keynote speaker for today's program, Miss Mo Kantner. Mo is Senior Director of Policy and Research at the American Immigration Council, one of the nation's leading research centers on immigration. The council focuses much of its attention on the economic impact of immigration policy. And in case you don't know, the council has, over the last 3 years, published 3 studies on the economic impact of immigration in 3 of New Jersey's counties, those being Mercer, Middlesex, and Passaic. Earlier this year, the council produced reports on the role of immigrants in the healthcare sector in 13 different states. And so we are very privileged to have Mo leading off today's program. With that, I will say welcome, Mo, and thank you for joining us today. The floor is yours.
Great. Well, thank you, Kyle. I really appreciate that. Thank you for the introduction. Thank you for having me with you all here today. I'm really excited to join today's conversation. And this conversation is particularly important to me, not just because I am a huge fan of speaking about immigrants in the workforce, but because I actually moved to New Jersey myself about 6 months ago out here in Asbury Park. So this literally hits home for me. But again, my name is Mo Kantner. I am the Senior Director of Policy and Research at the American Immigration Council. The council is a nonpartisan nonprofit organization. We make the case for common sense immigration policies through original research, through federal, state, and local organizing and advocacy, through litigation, through narrative change, and through direct service capabilities. So at the council, we really work to educate and inform policymakers, the business community, immigration lawyers, and the general public And so as an organization, we're really working towards a fair, just, and humane immigration system that works for all Americans, a country that really understands immigration to be its greatest competitive advantage, as well as inclusive communities where everyone can call this country home and can thrive. So I really want to just sort of set the stage a little bit for today's conversation and to give a bit of context for the conversations to come. So this will not come as a surprise, but the continuing trend over the past few decades is pretty clear. The median age of the US population is climbing. So the 2020 census data showed a continuing decline of birth rates in the US, and by 2065, the median age will be 42. We have baby boomers retiring at rapid rates, with 10,000 baby boomers turning 65 every single day. So this means you have a dwindling supply of workers as older workers are reaching retirement age. You have a smaller supply of young new workers entering the workforce. And then particularly for the healthcare industry, you have an older population that is increasingly reliant on the services of the healthcare industry. So you have a dwindling supply on two fronts and a ballooning demand. And any economist will tell you that that is a recipe for disaster. So with that in mind, immigrants are going to be an absolutely critical part of any community and economic development strategy, but particularly within the healthcare industry. So diving into some of the nitty gritty. So part of the work at the council is really working with business leaders and interested parties like you all to better understand immigration as a workforce issue. So as states across the country, including New Jersey, are grappling with meeting this growing workforce need, states really have the opportunity to support some innovative policies or programs that can help attract or retain immigrant talent that's really complementary to the US-born workforce and can also build career pathways for immigrants who already call New Jersey home. So across the country, we have 80.1 million of the 165.4 million expected open jobs in 2030 will be vacated by people retiring, changing careers, or leaving the labor market altogether. So the healthcare industry is already seeing really critical shortages across the country, and this demand for workers is expected to rise substantially over the next few decades, again, as we age as a nation and as we continue to need access to quality care. So as this graph shows, both healthcare practitioners and healthcare support workers have really high growth projections by 2030. And so looking specifically at New Jersey, as of 2021, immigrants make up about 23.1% of the population in New Jersey, and they make really vital contributions across the state. And then council research has also found that more than 23% of immigrants had a bachelor's degree compared to about 26.8% of the US population, but 18.8% of immigrants in New Jersey have a graduate degree, which is higher than their US-born counterparts at about 17%. Additionally, we have over 18,900 students at New Jersey colleges and universities that are really going to be a key part of talent retention across the Garden State. And then more than 40% of STEM workers in New Jersey are also immigrants. So we hear a lot about the need for physicians and for registered nurses, but we're also seeing a growth in demand for healthcare jobs that require the types of credentials that one can access through community colleges as well as vocational programs. So for example, over the last year, the top in-demand job postings included registered nurses and nurse practitioners, but they also included occupations like licensed practical and licensed vocational nurses, health technologists and technicians, and then clinical laboratory technologists and technicians. And then more broadly, the demand for all healthcare workers has really continued to grow in New Jersey, especially going between 2018 to 2022. So between 2018 and 2022, we saw a 69.3% increase in job postings for all healthcare practitioners, which is as well as a more than 70% increase in job postings for healthcare jobs, excluding physicians, and then a 46% increase in job postings for physicians alone. And then we also know that our nation and New Jersey's demographics are shifting a bit. And so there's an increased need for multilingual and culturally competent employees. And so immigrants and their children often tend to be really valuable employees in this particular area because of the skill set that they have. And that's why the number of healthcare job postings that required bilingual skills in New Jersey increased by over 100% during the same 4-year period. And we also know that immigrants are already playing a pretty critical role in the healthcare field as is. So, this includes fields that can require varying levels of education for certification across the entire healthcare spectrum. So, immigrants are 23.1% of the population, but they are 28.3% of the labor force. They are 29.4% of workers in healthcare occupations. They're 41% of physicians and 30.2% of surgeons. And then we know that there's a growing need for healthcare workers in New Jersey, but many immigrants who have received specialized education or training or licensing abroad can sometimes are sometimes unable to actually practice in the state, and they face a number of challenges, whether that is recredentialing or language proficiency. So their skill sets are really often underutilized, and so it's something that we call brain waste, which can lead to under or unemployment. So in New Jersey, 20.9% of immigrants, as compared to 21.2% of US born residents, have a biology or healthcare related bachelor's degree, but worked in an occupation that did not require one. Now, New Jersey is better than some states, but in a number of states, there are a number of barriers to occupational licensing and credentialing that really close the door to immigrants at a time when that state is in real need for this workforce. So that can include some of the young citizens who may have come to the country as children, like DACA recipients, TPS holders that may have work authorization, as well as some internationally trained professionals with some type of status that makes them work authorized, but who still face a number of barriers to practicing in the field. So although there's a growing need for workers, many immigrants cannot practice in specific states. So this is typically a result of policy barriers, which I know a number of my other fellow speakers are going to address in more detail in a little bit, but these can include things like requiring US citizenship or a social security number, not recognizing or accepting credentials or experience gained outside of the US, whether that is the cost or the price of credential evaluation or translation of materials, whether that is being overlooked due to lack of US-based experience. It can be a lack of clear pathways to re-credentialing or relicensing for internationally trained professionals. It can be certain English language requirements that really lack opportunities for vocational ESL classes and that training that can help folks work towards the credentials that they need while gaining the English skills that they'll actually need to use on the job. And it can also include lack of professional networks or support in navigating the US job market. So, a number of other states have taken actions to address these barriers, but I will say businesses can provide a really crucial voice to highlighting the need for cutting red tape and removing some of those barriers to meet that long-term labor market growth. And so this is a long battle, but there are several ways that industry leaders and business community can really continue to be a strong voice in advocating for some of these common sense immigration policies that will allow you to better tap into some of that domestic and international talent pools. So some areas where folks that may be listening in could have a particular impact could include at the federal level, with federal legislation or administrative actions. Some folks meet regularly with the congressional delegation, and while things can feel really hopelessly gridlocked in Washington, it's really vital to keep the drumbeat of this need for action. And so that can include policy meetings with senators, with Congress members. It can include publishing op-eds, joint letters, continuing events, and really voicing the importance of removing these barriers for qualified immigrants to enter the workforce. And then at the state level, sort of the first step that we always look at is really educating members. So this is a great opportunity for certain business leaders or industry leaders that to meet with state legislators and can use data to help educate these legislators about the economic contributions of immigrants within their area, within the region, or within the state. Some business groups also publish policy priorities that emphasize the importance of immigration and some of the barriers that a number of immigrants and refugees face when they enter the workforce. And then this can also include, pushing for policies that provide funding for vocational ESL and other experiential learning programs and things like that. And then the last thing, there's a number of things that we do when we push for narrative change in education. So we work with a lot of leaders when it comes to authoring op-eds and letters to the editor to really help continue to educate the general public as well as legislators, really trying to change that narrative from the ground up. So we've, over the past few years, placed over 800 op-eds from Lewiston, Maine to Long Beach, California, to really try and help move the needle on issues like this. And these mechanisms can really help the overall community better understand the economic contributions of immigrants, as well as the barriers in place. And before I wrap up, I just want to leave you all with one other resource. So at the council, we have an interactive tool called Map the Impact that has top-line data on the economic contributions of the immigrants. It is broken down by all 50 states, all 435 congressional districts, the 100 largest metro areas, all 2,000 counties across the country. And we did just recently release newly updated national and state level data for 2021. So really hope you'll dig in, learn more, and I really hope that you can use this data to continue to inform others, continue the conversation about immigrant communities, both across New Jersey, as well as their contributions to the healthcare sector specifically. And so you can help build policies that will provide a place for everyone with the opportunity to thrive. And with that, I just want to thank you all. I believe we're going to switch over to the panel for now, but I'm going to stick around. Happy to answer any questions after the panel has wrapped, and I will hand it back over to Kyle.
Well, thank you so much, Mo. Thank you again for being here and for your presentation, which was so enlightening in a number of ways. And we look forward to hearing any questions that the attendees of this morning's session have for you when we get to the Q&A. But with that, it is my great pleasure to now introduce Rachel Rosenthal, who will be moderating our panel of representatives of New Jersey organizations. Rachel currently serves as a member of Bloomberg's editorial board, where she specializes in health policy. Previously, she was an editor and columnist at Bloomberg Opinion, where she wrote extensively on labor and immigration. And for that, she worked as an editor and reporter at the Wall Street Journal. And before I turn things over to Rachel, I do just want to mention that Catherine Tisch, executive director of Einstein's Alley, and one of the co-founders of the New Jersey Business Immigration Coalition, will be monitoring both the chat and the Q&A section again for your questions, and we'll be moderating our Q&A panel, our Q&A session after the panel discussion in a couple of minutes. But with that, I want to thank Rachel again for being here and for honoring us with her presence, and I'll turn the program over to you, Rachel.
Thank you so much, Kyle. You forgot the most important tidbit, which is I'm a New Jersey native. But it is a great privilege for me to be moderating today's panel discussion. We have a distinguished group of panel members who will share their perspectives on the role immigration plays in New Jersey's healthcare sector. I'd like to begin by introducing them to our audience. In the interest of time, I can't cover all of their professional accomplishments, but I will try to tell you enough to appreciate the wealth of experience they bring to this larger conversation. And so maybe everyone could just wave as I go through. I'll start with Dr. Lydia Albuquerque. Dr. Albuquerque is an assistant professor at William Patterson and head of the university's nursing program. She started her career as an immigrant nurse from India, recruited by the Barnabas healthcare system in 2004, and later became the president of the National Association of Indian Nurses. Our next panel member is Laura Atkinson, who serves as vice president and chief human relations officer for St. Peter's healthcare system. Laura has 2 decades of experiences in the human resources field. Prior to joining St. Peter's early this year, she worked for 10 years as Chief Human Resources Executive of Ascension, one of the nation's leading Catholic health systems, consisting of 20 hospitals and over 10,000 employees. Our next panel member is Nancy Fitterer, who has been president and CEO of Home Care and Hospice Association of New Jersey for over 5 years. Before joining the association, she worked for 8 years in the New Jersey Attorney General's office, where she served as chief of staff for 2 New Jersey attorneys general. Nancy also served as chief of staff for the New Jersey Division of Consumer Affairs. Our next panel member is immigration attorney Stacy Simon, who is a partner with the Minor and Landis law firm in Newark. Stacy has been practicing immigration law for about 20 years and has a wealth of experience dealing with healthcare-related immigration matters. And last but not least, our panel includes Omna Saeed, Senior Policy Analyst at the New Jersey Hospital Association, a nonprofit trade association with 400 members committed to improving the health of all New Jerseyans. Before joining the association, she served as a health policy scholar at Rutgers Center for State Health Policy. So thank you so much, all of you, for joining us, and thank you for bearing with me through those introductions, but I think they were well worth your time. So I'm going to begin by asking a sort of open question and I hope that we can hear from each of the panelists. What brings you to the table? Why is immigration an issue of importance to you or the organization you represent? So why don't we, we'll maybe just go alphabetically, since that might just be the easiest. Lydia, why don't we start with you?
Thank you for that introduction, Rachel. So this is concerning because I'm an immigrant nurse and I have been reading a lot of reports. And a recent report from McKinsey and Company has estimated that by 2025, there will be a shortage of nurses. And I'm particularly talking about nurses. There will be a shortage, or there is a 10 to 20% gap that is equating to a shortage of 200,000 to 450,000 nurses throughout the United States. And the shortage actually is compounded to a greater extent because of various reasons of burnout due to COVID-19 and other factors that I will be discussing in my next question. So that's the reason I'm on this table today, to talk about nursing shortage.
Yeah, the data is gripping, to say the least. Laura, what are your thoughts on this topic?
And good morning. I think just in general, healthcare is facing a workforce crisis, and it's going to intensify as the need for complex healthcare grows. Nursing schools are struggling to expand capacity, graduate more students, meeting that rising demand of care. There's going to be significant workforce shortages due to retirement, stressful work environments, staffing shortages, burnout, just these professionals leaving the profession altogether. So the time to act is now. The policy changes that we need are now. This is just really what I think the perfect storm with some significant headwinds.
I can underline all of those things with a huge marker if I could. Nancy, what are you seeing on your patch?
So yeah, I agree with everything that's already been said. So when I worked at Consumer Affairs in 2010, one of the things we talked about was the nursing shortage, and that there was a nursing shortage then, and that it was only going to continue. So fast forward, it's been 13 years, and clearly the nursing shortage has only gotten worse. And I think, we've all been talking about it, but I don't know if there's been so much concrete steps that are done. For the Home Care Association, I get calls every day from patients and families saying, I need a nurse, I need an aide, I need a therapist. And, I try to help as best I can, but the shortage is real. There just are not enough nurses to take care of the folks at home. People are much more medically complex, either in the hospital or at home. Like, we are taking care of really medically fragile people, and we don't have the staff to take care of them. And this was pre-COVID. There weren't enough nurses and aides and therapists pre-COVID. And then, of course, as we know, COVID exacerbated everything. So not only did we have people leave the profession in droves, and not only was there burnout, but, a lot of people decided to not even go into the profession, right? And decided this isn't something that I'm interested in doing. So, and I will say the immigrant workforce and the immigrant population has such an extreme impact on our nurses in home care. We employ so many qualified immigrants, and we need to employ that many more, to continue. And there are so many steps that we need to take, but it's a crucial issue. Thank you.
No, I'm so glad you raised the COVID issue, because I think a lot of people have framed this around COVID, but it existed well before COVID. And I think even as COVID has subsided, we're seeing that this is a really pernicious and stubborn problem that's stayed with us, and we need some new, fresh solutions to a very old problem. Omna, what are you seeing in terms of, in your space, and why do you think immigration is so important?
Yeah, first I want to thank, the organizers for this event for allowing me to be part of this discussion. I think, as Mo pointed out in her stats, immigrants make up a large portion of our current healthcare workforce. And, if we're not able to address immigration policies that exist, we're not going to be able to fill the vacancies that we've been using them to fill, currently. If we're not addressing the red tape that we have, we're not going to be able to fill not just nurses, but, as Nancy mentioned, the respiratory therapist, physical therapist. So I know we're really keen on addressing those, because also it's also really important that we have a population of providers that reflects the population being served. I think it's really important that we talk about the diversity part of this. And, I think, that's a part that's often overlooked. So from the association's perspective, that's definitely where we, are really focused on.
100%. So we're going to go back to each of you with some specific questions. Lydia, we touched on some of this in some of the preamble comments that we've received so far, but there's a projected shortage of nurses in the state of New Jersey and the U.S. overall. How specifically could immigration policy change or mitigate this problem?
Thank you for that question. Actually, it's a burning issue right now. Nursing shortage is a burning issue. So I just want to highlight a few things, some numbers, so that we understand the gravity of the situation. In the United States, we have about 6.9 million nurses, and of which 1.1 million are immigrant nurses. So that's a huge number contributing to the healthcare system of the United States. Now, coming to New Jersey, and I have taken this data from the New Jersey Collaborating Center of Nursing Data Analysis report of 2023, we have about 173,000 licensed registered nurses in New Jersey, of which only 141,000 are active and 32,000 are inactive. We have about 16,000 APNs licensed and active, and also LPNs. We have about 29,000 LPNs, of which only 23,000 LPNs are active and 5,000 are inactive. So it is predicted that by 2030, we will have the following vacancies for jobs in New Jersey. For RNs, we'll have 88,000 jobs available by 2031. LPNs, we'll have 18,000 jobs, and NPs, we'll have 10,000 jobs. Now, in the near future, this prediction is about 6% for RNs, 4% for LPNs, and 3% for nurse practitioners. Now, how is this situation mitigated currently in the state of New Jersey? We have 48 nursing schools that happen to offer the RN education program, that is the pre-licensure and the post-licensure program. However, there are applicants that are rejected because of the reasons, that is lack of clinical sites and lack of availability of faculty. So even if we talk about, training, there are some barriers that have to be taken care of before we actually reach out to these numbers. And how are we going to reach out? And we need to have some solutions, right? So the American Association of Colleges of Nurses reported that there is 91,000 applicants that were rejected in 2021. So this actually is a huge number of applicants that have been rejected. And there have been various legislative laws that have been passed to increase the number of nursing training schools. But unfortunately, I do not know whether these changes will affect or will improve the number of nurses that are required in the future. There's a lot of investment, up to $25 million, that have been done into academic program grants. However, the faculty shortage is, impending admissions into the nursing schools. There are other actually solutions that have been looked into, and there are reports that have been created. That is the Nursing Solution Inc. They have made several recommendations actually to retain nursing staff and also to bring back retired nursing staff back into the workforce. And, that's happening today after COVID. That was one recommendation that came through. The Tri-Council of Nursing actually in 2021 report came up with 22 actually priority topics. And one of them is equity and health equity in all these programs, interprofessional emergency preparedness. Now, in spite of all this, we still see there is a shortage. So what is the answer for this shortage, or what is the answer for this shortage of nursing? Will a visa reformed proposal help in in improving or increasing the number of immigrant nurses. Now, we must remember that nursing is a Title A job, right? It's a Title A or a Scheduled A occupation. Nobody is going to take away the job opportunities for the nurses in the US. But however, immigrant nurses can provide a steady stream of qualified nurses to fill the job vacancies, right? So if this bill is passed and there's a vote yes, this will bring more nurses into the country to mitigate this emergent situation that the US is going through. Now, why does this need to be addressed? Because by 2030, there will be 70 million people. That means 21% of Americans will be 65 years or older, and they will require more health care. Fewer nurses will cause patients to face significantly higher mortality rates. And if there is inadequate staffing, it will cause adverse outcomes like medical errors and greater opportunities for infection. So there are countries that are looking or are able to provide nurses because they have the same education. So my plea is that the U.S. State Department has halted the access to the work visas. The American Bar Association has also said that this needs to be looked into, and the visa backlog has to be elevated. So if we take into considerations all recommendations made by various organizations and also make a change in the immigration policy, which is backlogged, probably the U.S. healthcare system will not be affected, or our U.S. population will not have high mortality rate if we have the adequate number of nurse-patient ratios. Thank you.
Thank you so much, Lydia. And Stacey, I'm sorry, I skipped you for the first initial question, but I think it's actually a natural transition point to turn to you next. Maybe you could offer a double-barreled answer, both your broad view on why immigration is important, but also some of the reforms specifically related to doctors. You know, you've discussed that one way to increase the physician supply in the U.S. is to reform the Conrad 30 waiver program. So maybe you could give us also a quick summary of that program and what the necessary reforms might be that would address some of these same questions that we're seeing in the physician space.
Absolutely. Thank you for having me. This is such an important conversation to be having. Immigrants, as we all were discussing, are just an essential part of solving the shortage problems that we've experienced for such a long time, pre-COVID and especially post. With regard to physicians who train in the United States, and this kind of takes from where Mo left off forward, because Mo was talking about the barriers to credentialing. But once you are credentialed, there's a whole new set of barriers. So for physicians specifically, they are at this point forced to train in the US in J1 status. They used to be able to train in H1B, and now every single hospital requires their residents to train in J1. And the significance of that is a clinical physician in J1 status automatically is hampered with the home residency requirement. And that is a 2-year requirement that one spend 2 years in their home country, and it must be in the home country, to bring the skills that you gained in the US back to your home country to benefit your home country. It can be waived in most circumstances, unless you have a Fulbright. It can be waived. The waiver process has become not only difficult and burdensome and complex, but they're so inadequate. So the Conrad 30 is the most common type of waiver for a physician to get to the home residence requirement. It requires you spend 3 years in a medically underserved area, which is wonderful because that means not only are we getting physicians, but we're putting them where we need them. That's great. However, there's no sliding scale of proportionality. So the Conrad 30 is aptly named the Conrad 30 because there are 30 waivers per state. That means there are 30 waivers available to physicians per year in North Dakota, and there are 30 Conrad 30 of these waivers available to physicians in Iowa, and there are 30 waivers available to physicians in New Jersey, which is woefully inadequate. I'm actually old enough to remember when it was the Conrad 20, and dating myself, and about 20 years ago, I've actually been practicing now closer to 25 years, it was raised to 30 to address this, and it has been for 20 years, that number has been stuck at 20, which is remarkably inadequate. So one of the things we need to do is raise that number, and maybe a sliding scale, because your medically underserved area has to do with proportionality, your proportion of available physicians to the population who needs physicians. To meet that criteria in, let's say, North Dakota, there's certainly going to be a disparity, but that disparity is so much more significant in New Jersey of shortage. There's no reason why that number shouldn't be proportionally higher in certain states and maybe lower in others. Some states don't use their 30 in a given year. So a physician can have a J up to 7 years. So what ends up happening is, so you train a general practitioner will train for 3 years, a specialty will train for 4 years. And if you don't get chosen for one of the 30 waivers, you'll keep training. Some will go into fellowships, and you'll get a few more cracks at the Conrad 30, and those in their 7th year maybe prioritize a little bit more. But there are some that will just not get the Conrad 30. Other waivers exist. There's the VA waiver, and certainly our VA hospitals need physicians as well. But the VA is being put in a position where you apply for the waiver, you make this offer to a physician, but it takes almost a year to find out if the physician is approved to the waiver. Now, in the meantime, you've tied up the position, because the VA has given that, offered that position to somebody, where maybe if somebody else came along, could you give that position to somebody? Maybe you do, because you need that physician. You hire that physician. Now what happens to the person who's been applying for the waiver? They're 8 months into a waiver process. They've lost the position, right, for good reason, right? You're not going to hold this position open for a year for your waiver applicant. You're going to hire somebody if they come along. Now, what happens to your waiver applicant? You might be in your 7th year of J, and the VA waiver was where you got left off. Now what? Now you're going to go home. Now we've lost a physician. That is a significant gap that's fairly fixable. I don't think there's anybody that would deny that states like New York, New Jersey, maybe California have a much more significant shortage. That proportionality of medically underserved is much more significant. And we can maybe reallocate the numbers in states where they're not used. There are states like North Dakota and Iowa where 30 waivers are not even being given.
Sure. I want to give Omna a chance to weigh in here, because you've actually pointed out that New Jersey faces a disadvantage when it comes to competing for foreign medical personnel because of a limited number of areas designated as health professional shortage areas and medically underserved areas. So can you explain a bit how areas receive such designations and whether they can be expanded?
Yeah, of course. So New Jersey is at a significant disadvantage when it comes to utilizing these programs that Stacy just mentioned. As she mentioned, right, there's only a certain amount of slots. And because, I mean, you guys might be surprised to hear, New Jersey is actually federally considered a all urban region. And most of the definitions, or the definitions for HPSAs and MUAs, are largely catered towards rural regions. So please don't mind, I'm going to read the definition so I don't get it wrong. HPSAs are a geographic area, population group, or healthcare facility that has been designated by the Health Resource and Services Administration as having a shortage of health professionals. And the 3 health professionals they're looking at are primary care services, mental health services, and dental services. And so based on HRSA's guidelines, the only places that are considered that are under these that are applicable under these guidelines are correctional facilities and federal qualified health centers. So no acute care hospitals. Some doctors' offices will count, but not really. So this has made a challenge for our providers to utilize these programs that are using HPSAs as an eligibility criteria. And for the Conrad 30 waiver program, HPSA is a criteria for qualifying for, being applicable for the waiver, and even our state loan redemption programs. And then MUAs, which is a bit more expansive, it includes looking more at economic, cultural, and language barriers. But still, the way the MUAs are defined, only certain regions of our 16 of our 21 counties qualify. And like I mentioned, regions, not even the entire county. So New Brunswick qualifies, but not the entire Middlesex County. So again, I think we need to look at these definitions, and these definitions aren't updated frequently. We need to make them more expansive, because our members state that, they'd love to use these programs, but there's just so many barriers. There's just so much red tape that we can't utilize it. And, you know, I think, you know, New Jersey needs to be given the opportunity to do so. You know, we need to make it more expansive. We need to make it more inclusive. We need to look at our, you know, social determinants of health. We need to look at the populations that aren't, you know, concentrated to one geographic location, such as our homeless population. So, you know, there's a lot of work to be done. And then quickly adding on, I know there's federal legislation that is looking to expand to 35, but you know, sliding scale could also be, I think, something great to look at, because right, not all states utilize all 30 of their waivers.
That's a really comprehensive answer. Thank you. And, you know, I think we're going to hear and have heard already a lot about red tape, particularly from Mo's introduction, but I wanted to pick up on that. And I was hoping, Laura, you could weigh in here. You've raised the issue of how hard it is for immigrants to get recognition for their foreign earned credentials. I think this is such an important point that does not get enough attention. Could you please elaborate, you know, on this and just offer some suggestions for ways that policymakers can streamline this process, because we've seen all these folks who are sitting on the sidelines, and yet we've got this ballooning need.
Absolutely. And, you know, this is indeed a significant issue that many immigrants face. When immigrants come to a new country, they often find that their foreign earned credentials, degrees, diplomas, professional certifications are not recognized for a variety of reasons, educational, professional standards, language barriers, whatever it may be. So this lack of recognition does pose some consequences. It could prevent immigrants from securing employment in their field of expertise, forcing them to take lower paying jobs for which they're overqualified. This not only impacts the person, but their family, and then the economy, the host country. We miss out on those skills and expertise. So a story last May posted in Stateline shared that it took 11 years for a gentleman to complete his training in Russia to become an interventional cardiologist. That's a doctor that places stents in clogged arteries. After that, he practiced 5 years, ultimately becoming head of his hospital's cardiology and radiology department. He then immigrated to the US in 2015 at age 32 and had to basically start all over again. He spent 7 years studying English, preparing for the rigorous US medical licensing examination needed to qualify for an American residency, which he began last July in Brooklyn. For him to get back to performing these invasive heart procedures, he'll have to repeat 3 years in residency, 3 years in general cardiology fellowship, 1 year in fellowship for an interventional cardiologist. He will be 47 when he's done. So there are solutions to this problem. And to begin, one solution would be to establish equivalency standards. I think government and professional bodies could work together to establish these standards for foreign credentials. It would involve assessing the content and quality of those foreign qualifications, determining their equivalency in the host country. And then if there's gaps within competency, that's what the immigrant can be responsible to overcome instead of repeating the entire medical residency and fellowship. Thank you.
I think you saw a lot of nods among the panelists. So I just a testament to how frustrating and yet important what you're talking about is. I want to turn to Nancy because she's also on the front lines of this. In a slightly different aspect, there's an effort underway to grant work authorization to asylum applicants and other categories of provisional workers. Are you seeing any improvements in worker availability as home health aides as a result of that effort?
So unfortunately, no, only because I think, so when the legislation was passed, I think it was passed last year with the good intention that to talk about exactly what Laura was saying, you know, they are qualified, or they'll either go through a training program because we have such a shortage. But even though the Division of Consumer Affairs is allowed to license them, and the license checks are a little easier because there's not an immigration status anymore. So that used to take up time. Now it doesn't, which is wonderful. However, especially for our certified home health aides, the way the regulations in New Jersey work, you must have a promise of employment from an agency. And our agencies can't give a promise of employment unless a person can show all the documents needed for an I-9 form. And so there's been a lot of confusion because you will have somebody who, and there's been a push to have folks go through these programs, which again, we love, but it's now they're getting mixed information. Like, hurry up, spend your own money and go through this training program. They go through all of the training, and then they look for, one of my agencies, and they say, hey, I want to be a licensed home health aide. I went through the training, please hire me. And then our agency says, yes, we'd love to, give us all of this information that we need. And then they look at them and they're like, well, I don't have that information. And then we'd say, well, we can't hire you with that information. And then, they kind of give us a look and say, well, then why did I go through this entire process? And so I think the goal was so worthy, but we're just not there federally. So we need some steps to be taken to allow us to hire folks. So that's issue number one. And then, just a federal issue, retrogression. So there are so many folks that we have that are waiting and are patiently waiting online to be able to get their chance to come. And there really should be retrogression for just healthcare workers, whether it be doctors, whether it be nurses, whether it be any profession, that they'll still have to go through the challenges that Laura has outlined many times, but at least they're here in New Jersey. I mean, for our nurses, our Board of Nursing can be challenging and they can give us some issues with licensing them. But if we can show they've got all the qualifications, we can bring them here and get them licensed. But that's almost the last step. Like there's a lot of steps in between that they need to even get here. But I mean, I have agencies that predominantly work, and find nurses from other countries as they're trying to find nurses here, right? Like doing a dual track, they're going to try to find nurses from other countries, and, they host them and they do all of the, immigration paperwork for them so they can get here. But again, once it hits a certain number and it closes, then there's nothing we can really do about it. So
can I add something to what Nancy was just saying, because this is very relevant. It's remarkable, and this is a policy issue that should be so easy. It is not controversial. It is not politically charged at all, which is there used to be a separate quota for Schedule A. So when Schedule A was first established, there was a quota of 50,000 for Schedule A nurses, and when it was exhausted, it was never reallocated. It was basically the unused numbers from other categories from 01 to 04 that were allocated. It was never reallocated because there is a shortage, and only Congress can do this. The Immigration Service has no authority to allocate immigrant visa numbers, but there is no political issue in allocating numbers to a shortage occupation, right? This has been 20 years and they have not reallocated these numbers. The same thing for the H-1C. There was a nursing non-immigrant visa category. Granted, they're, woefully inadequate, 500, medically underserved area. And of course we need to reevaluate, we were talking about what that means, but so that would expired in 2005. This is almost 20 years ago. How did 20 years pass in a shortage occupation when we cannot reallocate numbers to this? This should not be controversial at all. Very simple. So yes, it's a backlog issue, but it's so easily solvable. This is one of the policy issues that we're here to talk about.
Sure. And so what I want to do just while we're concluding is maybe this is a natural point for everyone to go around and say, if you could advocate for one policy reform that would improve the healthcare delivery in New Jersey, what would that be? So why don't I'm just going to go in the order of my screen so I don't accidentally miss anybody. Again, I'm so sorry about that, Stacy. Omna, could you start? What is one policy that you would advocate if you could have the floor of Congress right now?
Sure. If I had that magic wand. No, I think, we spoke about the red tape. So any policy that kind of mitigates that. So I know there is legislation right now that would actually recapture 25,000 unused immigrant visas. And within that legislation, they would expedite the process of those, those applicants, because, the green card backlog is immense right now. So, if you could apply that expedited process to even the, the applications that are in the backlog, that would be game changer and, would help bring us, all the immigrants that could help fill all our vacancies that our, domestic population can't fill. So that would be, the ideal policy.
Lydia, what about you?
So I have been schedule a that ended in 2005, the 50,000 immigrant nurses that were given the green card. And after that, nothing was being done, right? So there were people still waiting for their green card in the processing, and this red tapeism has taken over. And there is no move because it takes about for immigrants actually for nurses to immigrate to the US, it depends upon the country of application. So each country has a spot of maybe waitlisted or backlog, anything that ranges from 1.5 years to 5 years to 10 years. So I think for priority occupations like nursing, medicine, healthcare providers, this needs to be elevated. The Congress actually should take away the limit on the number of green cards, or they can put a limit and say, we would, sanction 50,000. Why wait for 2030? Why wait for 2060? Why put our, our patient population or our U.S. citizen or our population at risk for high mortality or infections or things of that sort? So I think lawmakers, policymakers, they need to look into this. This is an issue. A lot has been done in investing in various bills that I have spoken about, like, eliminating the practice restriction for APNs, that is the S1 522, then also providing 25 million for academic program grants, and also nurse faculty loan redemption. Everything is being done. Everything is being done, and it still continues to be done, but we have a shortage. Isn't this a reality? Shouldn't we talk about this? And shouldn't the lawmakers make some changes and bring that same thing that was done to Schedule A workers and stopped in 2005? The retrogression is hurting the U.S. healthcare system. It is hurting because we have the shortage of nurses. So I would say, do what you can do at a fast pace. Think about it.
Amen. And I think what really singles this area out from, we saw shortages across the labor market in the US during and after COVID, but this is really life and death. And I think that we need to that urgency needs to be appreciated. Stacey, you've had lots of great ideas already, but if you could had your magic wand and could focus the minds of legislators on one, what would it be?
I'm going to now look at the non-immigrant visas, which are the temporary visas. There are two very obvious, again, non-controversial, non-political hot buttons, which is we've got the H-1B quota, which is a problem as well for non-immigrants. So physical therapists are eligible for, not just nurses, physical therapists sort of shortage as well. They should be exempt from the H-1B cap. You shouldn't have to work for a hospital or exempt institution to be able to get an H-1B. You've only got 85,000 H-1Bs and hundreds of thousands of people vying for those spots. And you've got physical therapists and nurses. Not all nurses qualify for the H-1B, but a lot do. And you've got nurses and physical therapists in line with hundreds of thousands of people who are put at the exact same priority as an accountant. No, certainly not knocking the accountants. Sure, they're great, but this is a different issue. And the H1C, by the same token, there's no reason not to pump more numbers into the H1C and adjust it where it's not as limited in general to medically underserved areas. It's a shortage. We've all acknowledged this. Department of Labor has acknowledged this. So you've got a category made for nurses, reinstate it, and then you've got the H1B where physical therapists are stopped by the quota. Exempt them from the quota.
Right. Yeah. I mean, not to knock our computer engineers, but
they're sitting in the same line.
The structure of that visa is so heavily tilted toward, and it's how is a nurse supposed to compete? And I've spoken to many employers who are, in this boat, and it's really hurting the American people and everyone who's here. Laura, what would your policy reform be?
I think it would involve streamlining the process for evaluating and recognizing those foreign credentials, providing that support, the resources to help these professionals navigate the licensing process, working with healthcare organizations and employers to really promote the hiring of these people as well. I think in New Jersey, this could really significantly improve the quality of healthcare by increasing the number of qualified healthcare professionals available to be able to serve our diverse population. And as we think about diversity, it really will help to address those health disparities as well. They're going to be taking care of people just like them. And that's really improving access to that culturally competent care.
I was so taken by the stats on bilingual job postings from earlier. I thought that was really an important point, particularly in a state as diverse as New Jersey. And finally, Nancy, could you round us off with what your recommendation would be?
Sure. So everything, I'll say yes to everything that was already said on the federal side. But then on the state side, I mean, I think there's things that can be done. So, we employ nurses and therapists, of course, but we also employ home health aides, and other industries, employ, direct service professionals, certified nurse assistants. And there is, while the immigrant community does play a role in our home health aides, I think that certain immigrant communities are much more robust in our CHHAs than others. So it is, and that could be a language issue. That could be, it's just not something that they necessarily think of doing. So I think this is something the state can do, and I think the state is slowly trying to do this, going into our immigrant community, whether it be our new Americans or folks that have been here a long time, and really stressing what it is to be a home health aide, and really any of our medical, it doesn't need to be kind of the nurses, the doctors, the therapists. It can be some of our other professions, and talking about what it means to offer these services, to be part of the healthcare community, and stopping some of that red tape that takes so long for them to get licensed. It's kind of a whole other issue, but there are, Department of Labor has all of these, English as a second language courses that are for free. So it's marrying that. So I have someone that wants to be an aide or is thinking about it, but they're not proficient enough in English. Well, there are these free programs. Explain what the free programs are, work with them, and then kind of show them all of the different places that they can look for a job to make it easier. So this is kind of this isn't that difficult, right? I mean, this isn't something that you need an act of Congress to do. It's more just highlighting it and putting focus on it.
All such excellent recommendations. I want to thank each of the panelists for your insights today. Shortages in the healthcare workforce have been a stubborn problem. It's been exacerbated by a whole host of issues that we've discussed, but we heard so many smart ideas today. Hopefully, folks are listening. We can get these problems fixed. Thank you so much.
Thank you, Rachel, and wonderful panel. And you're not done yet, because we have some questions coming from the audience, so be prepared. One thing I'd like to start out by saying is we had a question about, will the recording be available? And it will be, and you will, if you are registered for this webinar, you will get a copy of the recording. I'm Catherine Kish, by the way. I am Executive Director of Einstein's Alley, a founding organization of the New Jersey Business Immigration Coalition. We've had a couple of questions that are a little bit overlapping, and I'm going to try and put them together. Could the panelists comment on the impact of bias, prejudice, and stigma experienced by immigrants in the health professions workforce? And what are some practical and effective strategies? And a variation of that is, how can we foster increased diversity, equity, and inclusion and belonging of immigrants in the healthcare workforce? Tools and resources that could be used by leaders and policymakers. Any ideas on that? Lydia?
Yes, let me address that question, especially in healthcare. So we have our organization, that is American Nurses Association, and what we have worked on is, there was a commission in 2022, a national commission to address racism in nursing that addressed diversity, equity, and inclusion to a greater extent. So some of the tools are available on the ANA website, that is the American Nurses Association website. Now, this is a real issue because immigrant nurses are not very familiar with distinguishing between racism in nursing and how it has affected them. They were silent, or they continue to be silent recipients because of the cultural differences that, you come into the country and you come from a different cultural background. But however, it is important that everybody is educated. And so right now there is an effort by the American Nurses Association to make a reconciliation statement with minority organizations, where the Caucasian nurses have actually, or the board of American nurses have gone out into the community and addressed and apologized for this racist behavior that has taken place all these years. The report actually spans over several documents. There are 6 documents that talks about racism in nursing and the effect of and the historical perspective of racism in nursing towards not only immigrant nurses, but also the Black nurses. So a lot of work is going on, and I was very fortunate to be part of this continuing work. And that's one way by which you can educate yourself. And also there are tools available on diversity, equity, and inclusion. And this is a big takeaway right now in all academic institutions and institutions where you have a diversity officer who addresses this issue. So it's important to voice out. I think it's important to speak up when you experience some sort of racism or some sort of disparity or some sort of inequity or some sort of issues at workplace, because there are forums that address this. But if you keep quiet and you are silent receivers and you silently receive or are on the receiving end just because of the color of the skin, or just because of the language barrier, or just because of the poverty, issues that individual families face, and you come to work because you need a job, and then you're worried that if you report, probably you lose your job. And that's not so in the current situation, right?
Good.
So,
well, thank you, Lydia. That's a very comprehensive answer. Does anyone else want to comment on that? Okay, we have another interesting question here. Are there states that are actively recruiting healthcare professionals, particularly physicians that waive the needs for residency if they've achieved specialization in their country? I've heard that some Midwest states are considering such action. Is anyone heard about this in New Jersey, and is this a possibility?
I will say that during COVID, there were a number of really innovative programs that were put forward. So, for example, in a few states, because the healthcare need was so dire during the pandemic, that there were some states that, for example, would allow folks, if they had practiced within their home country within the last 5 years and were residing within the U.S., they could basically practice under the supervision of another U.S. Licensed physician. So there were certain exceptions and things that took place during the pandemic because of the emergency need for it, that I think some states and some state legislatures are trying to figure out, consider if there are ways to codify that for a more permanent opportunity. There were, it was mixed results because there were such strict requirements in terms of, had to have practiced within their home country within the last 5 years. So it had to have been someone who was very recent who had arrived within the US. But it is definitely something that I know some states are considering and trying to figure out how to more quickly and efficiently streamline those that were trained and practiced in their home countries into the medical field within the US. And if that's not necessarily as a physician, sort of how do you, is there something at least within the healthcare field? So if you're a physician, can you work as a respiratory, something that sort of gets them along the career pathway, even if it's not in the exact position that they were within their home country. So it's an ongoing conversation. I think Paul Feldman came off for a hot second. The folks at Wes are looking at this too, but it is something that some states have considered and is definitely an evolving conversation.
Interesting. Thank you. And just to maybe as a last question here, is there any evidence of wages with the immigrant healthcare professionals in some way lowering the wage rates for jobs? Does anyone have any information on that?
The
I
wages
haven't-
for
Nancy?
Sorry.
I was gonna say, I haven't seen that. So I haven't seen that at all. I mean, we spend a lot of time advocating for higher wages, of course, but no, I've seen no evidence towards that.
So I would add to it, in the US, there is equal pay opportunities for everybody, whether you are an immigrant nurse or whether are a healthcare worker, it's equal pay opportunities. I remember I was working for Hackensack, and I don't mind saying this, the HR actually came back and apologized because they had not credited my experience in India, and my salary went up by X number of dollars because of that. And I thought that was very respectful of Hackensack. They're Hackensack Meridian now, but they did acknowledge my experience and consider that for me.
Good. Thank
Actually,
you.
I add to that something that within the immigration sector, it's required that immigrants or non-immigrants are paid what is called the prevailing wage. And prevailing wage is based on the Department of Labor's wage surveys. Their surveys are remarkably high. So immigrants tend to be paid, if not the same, sometimes more than US workers. So if anything, that is attracting foreign workers, because the prevailing wage for nurses, and it's broken down by geographical area and then within 4 levels. So it depends on your level of expertise, a level of experience. But within each geographical area, the government survey dictates the minimum salary. So it's not minimum wage, it's the prevailing wage, which does tend to be higher. So immigrants are not undercutting the US workforce as far as wages. If anything, they could be making more in most situations.
All right, good answers. Thank you. We have a comment from the audience, which is that New Jersey had a policy during COVID to allow for foreign licensed doctors to practice in the state under the supervision of a US licensed physician. And I see a lot of, that's one answer. Are there any, just as a final question, are there any things that you think the business and industry community can do to help move us towards some of these reforms that you have talked about? Where can we apply the clout of business and industry most effectively? Nancy?
Advocate. The business community is the one that's hiring folks. And so, they'll look at us as the policymaker, but they'll look at us and say, well, okay, you're the advocates for folks. But if you're talking to a policymaker, you are the business, you are the person that is struggling with workforce, you're the person that wants to hire these individuals. So kind of the louder their voice is, the more it will be heard, I believe.
Okay. Any other comments to endorse that?
I would say the best reports come out from Bloomberg and McKinsey. It shows that the business community plays a very important role in being the voice for healthcare workers.
Excellent. All right. Thank you so much, panel. You've just been wonderful. Really appreciate that. And now we're going to move on a little ways because our time is running out as always. And I'm now going to introduce the first of our concluding speakers, Cecilia Esterline, who is an immigration research analyst at the Niskanen Center. We've had some controversy about how the name should be pronounced. I'll pronounce it Niskanen. The center was named the most interesting think tank in America by Time magazine this year. And they just produced a most interesting annual report called Providing a Fresh Roadmap for a Divided America. Instead of split the difference by partisanship, the center is committed to something called transpartisanship, which means that there are great ideas on all sides in the political spectrum which should be considered as we work to construct solutions to the major problems facing our nation, including immigration. Cecilia will share with us today some of the legislative proposals that the center is working to advance in the area of healthcare and immigration. Cecilia, welcome and thank you for joining us today.
Thank you so much, Catherine, for the kind introduction, and to everyone for joining us today. I think the panel gave us a great overview of both the severity of the shortages, but also kind of gave us an idea of how localities are responding. So I just wanted to take a few moments to discuss what is being done and what can be done on a federal level. There's, of course, a lot going on with this issue. So, of course, I don't have time to go through everything, but I'm going to just highlight a few things that I believe do have a strong possibility of attracting enough bipartisan attention to move forward. I was going to focus a little bit on the Conrad 30 program, as it's a large part of Ms. Gannon's portfolio, but Stacy gave a wonderful introduction to that. So I just wanted to expand on it a little bit. As she mentioned, that is the program that allows J1 international medical graduates to waive their home residency requirement by serving in a medically underserved area or serving a medically underserved population in a state. And as she mentioned, it's a very small program, only 30 per state. But what we have found is just within the past 15 years, we have benefited from over 15,000 physicians who have served areas and patients with significant medical needs through this program. And they've served an estimated 44 million patients during that time. So even though it's really small, it has a very big impact. And this is really important, especially as we've mentioned, the needs of rural areas are incredibly significant. We have less than 1% of our last year medical graduates in this country who say they want to live in communities of less than 10,000, and still only less than 2% when you put that up to 25,000 or fewer. So the needs in rural areas are great. And the issue with the Conrad 30, besides the size of it, however, is that it was set to expire on October 1st. Thankfully, it has made it through on the continuing resolutions, appropriations acts that have passed over the past several weeks, but currently it is set to expire on February 2nd of 2024 unless it is reauthorized. So this is an issue that's come up repeatedly over the past several years, where various lawmakers have introduced legislation to reauthorize the program for an extended period of time and to expand it, as she mentioned, by offering ways for states to share unused slots or things of that nature. The Conrad State 30 and Physician Access Reauthorization Act, that was introduced by Senator Klobuchar, and it has the support of 22 bipartisan co-sponsors. It would increase the number of waivers to 35 per state per year, as so long as the state had used a significant share of their waivers in the year prior. It would also introduce mechanisms for increasing the number of waivers available in response to demand. So, of course, this is still a very small amount considering the anticipated shortfall of physicians in the years to come, but I wanted to highlight this program in particular to share how even the small wins, even these like small programs like these, have very significant impacts on thousands, if not millions, of Americans and the kind of care they are receiving and the kind of care they have access to. So that's kind of an example of what we've been doing and what I hope we will be able to continue doing if that is reauthorized. But I want to turn a little bit of attention to what can be done. A few months ago, my colleagues and I put together kind of a blueprint of what an immigration healthcare bill would look like in a narrow form that could still positively impact patient access and patient outcomes, but also attract the support and be palatable to very broad bipartisan coalition, as that's what we need to pass some things right now. So, of course, that includes the reauthorization and expansion of the Conrad 30 program I just mentioned. It also focuses on something called the American Competitiveness and Workforce Improvement Act. That act currently requires fees to be added to the H-1B petitions that we've mentioned are for specialty occupations. It's a visa program. It requires a fee to be added to fund domestic workforce development. And so far, those fees have funded $78 million in programming to train, recruit, and retain nurses in the US, in addition to $40 million in rural healthcare workforce investments. And this is really important because as much as we can rely on immigrants and continue bringing in immigrants to support our needs in the future as we address these population declines, we also have a responsibility to shore up our domestic pipeline of talent. And we can do that by expanding the workforce competitiveness and Workforce Improvement Act's fees to also apply to L1 intra-company transferee applications, which is another visa program, and that could add $45 million in healthcare workforce training funds for Americans. We also suggest that MD and DO programs be added to the list of degrees designated for STEM OPT. OPT, or optional practical training, is an optional extension which students can take advantage of to continue their studies. If they have come here on a student visa, they can continue their studies for 1 year after graduation through practical application in the workplace. And STEM OPT programs give them an additional 2 years, up to 3 years of optional training within the workplace. Now, the problem is that veterinary preventative medicine, pharmaceutical sciences, molecular medicine, all of those graduates are eligible for STEM OPT and therefore 3 years of work authorization following the completion of their studies, but medical school graduates are not. And as a result, as we've discussed, many foreign students at our medical schools really struggle to secure work authorization and often end up completing their residency outside the US. And as we know, not only residency is a really important part of a doctor's medical training, but in the United States, resident physicians play an incredibly important role in the provision of services to our patients. They work over 60 hours per week on average, and they treat over 80% of level 1 trauma care cases in the US. So keeping as many qualified residents in the United States as possible is really in our best interest to make sure that we don't lose the talent that we are already harboring here within our medical schools. Another federal initiative could provide a permanent legal pathway to DACA holders and dreamers who work in healthcare. And this is a topic that has come up frequently, and it frequently arose during the pandemic especially. But with the legal status of DACA recipients in near constant legal limbo, preparing a pathway forward for those who work in critical fields like healthcare is incredibly important. Now, I want to make a quick note to say that none of the ideas that I just mentioned would directly increase inbound migration and would instead focus just on maximizing the capacity and potential of the present workforce. And this is really important because that's something that can attract bipartisan attention and support. But if we are open to the idea and the possibility of increasing annual migration numbers, we could also exempt rural hospitals and nursing homes from the H-1B cap. So as we mentioned previously, the H-1B is a specialized worker visa that's meant to fill gaps in the US labor market, but it does have a strict cap, and it operates on a randomized lottery that this past year had only a 25% chance of selection. And even once you get past the 25% selection, then you still have to prove that you meet the qualifications for the program. So nonprofit hospitals that are affiliated with universities already benefit from a lottery exemption, but rural hospitals and rural nursing homes are often further from prominent universities and often lack similar privileges. So exempting them from the cap would not only improve their ability to meet their workforce needs in the short term by bringing in the people that they need, but as we discussed also with the fees, their fees would also shore up the domestic pipeline by funding the reinvestment into the training of American workers. Now, there are a lot of other programs and initiatives that are being discussed in terms of narrow action and in larger reform packages, but I really don't want to monopolize our time. So I think I'll stop myself there with just one final point. And that's to say that I do want to end on a positive note. There is a lot of attention on the lack of bipartisan legislation surrounding immigration, and that has generally been the case for the past maybe 3 decades. But I do want to highlight that last year, a bill really sailed through Congress with incredibly high levels of bipartisan support, and that was the Bridging the Gap for New Americans Act. And that is a very narrow bill. All it does is requires the Department of Labor to conduct a study and then report back to Congress regarding the factors that are affecting and impacting the employment opportunities for immigrants with credentials that they have obtained abroad. Now, of course, this is just a study and it is not a mandate for action, and we have not yet seen the results of that study. But as the barriers for healthcare workers in particular are quite significant, as all of the panelists aptly pointed out, I do hope that the resulting report will spur bipartisan action with the same level of support that the study itself did. So With that, I will end, and I'm happy to answer anyone's questions. Thank you all for the opportunity.
Thank you so much, Cecilia, and I'm so glad that your organization is working on these initiatives in Washington. Thank you. I'm now so pleased to introduce our last, but certainly not least, speaker for the day, Paul Feltman. Paul is the Deputy Executive Director for Global Talent Policy and Programs at the World Education Services, often referred to by the organization's initials, WES. The organization is dedicated to the goal of helping international students, immigrants, and refugees achieve their education and career goals in the United States and Canada. He heads up the program called Global Talent Bridge, which seeks to bring about systemic change to enable immigrants with international credentials to re-enter their professional fields in America, including healthcare. Paul will share with us what is happening on the state level to advance this goal. Paul, take it away.
Thank you so much. Pleasure to be here. And I'm going to shift our focus. I'm going to try at least. Delighted to hear from everybody on this challenge. And we've been working as an organization, we're a nonprofit social enterprise that supports the economic, educational, and social inclusion of immigrants, refugees, and international students. We work programmatically, but also very much in the policy realm at WES. And actually, our number one policy priority, couldn't be better suited to this session, is to expand pathways to licensure for internationally trained physicians, nurses, and other workers in healthcare. All of the most of the conversation thus far has been focused on what I would term the immigration side of things. And WES, of course, we look at many of the reforms and recommendations mentioned here and can only agree that there's so many problems to be fixed. Immigration is a federal responsibility about visas and status and who can come. Immigrant integration, and I'm going to focus on immigrants who are already here, that happens on the ground in local communities, it happens in states. And we, I think, do a disservice if we overlook the many opportunities that do exist for state intervention around boosting and supporting the healthcare workforce in New Jersey. It's a proud New Jersey, and I think let's look to Trenton a little bit. We have some really good allies and some good momentum, and I'll talk about that in a moment. The federal government, though, as Cecilia just mentioned, has supported the Bridging the Gap for New Americans Act, funds programs like workforce development, English language training, and refugee resettlement. So there are ways that federal actions also impact integration, but most integration, again, is managed, run, and funded at the local level. People have rightly pointed out previously, we talk a lot about the barriers and the deficits that international trained healthcare professionals and other professionals have in accessing licensing and employment. One big difference, our licensing systems are based on the notion that someone is a fresh graduate of a nursing program or a medical program, and then tests and proves themselves and does the clinical residency required to become licensed. Many, if not most, of the internationally trained healthcare professionals who are already living in the US, who don't need visas, who don't need sponsorship, who have work authorization already, not only are graduates of these programs, but they're highly experienced. Many of them come to the US with years of clinical practice and experience in their field, as well as the linguistic and cultural competency that has been shown to improve patient outcomes. So we are overlooking talent in our backyard. And let's talk about New Jersey and what we could do at the state level. First of all, New Jersey is already a leader. Mo mentioned, and someone else mentioned as well, the fact that New Jersey did, during the COVID pandemic, Governor Murphy was one of 6 governors who issued an EO, an emergency order, that allowed internationally trained physicians to be temporarily licensed to work under supervision to address that crisis. I want you to hear this number, because when New Jersey made this available and promoted it, there were more than 1,000 candidates who applied from across the country. And from across the country, about 50 or 60% were from the New York, New Jersey area. But from states around the country, this opportunity spoke to people who have been frustrated by their inability to re-enter the career in which they've been trained in their home country. Should give you an idea of some of the sense of opportunity that's manifest in immigrants who are already living in the United States. New Jersey is also a leader in another way. New Jersey is one of 17 states and was one of the earliest to create a state office of New Americans. Again, executive order by Governor Murphy, and I just learned on November 27th, legislation was introduced to make that Office of New Americans a permanent feature of state government, to nest it in the Department of Human Services, where it currently is anchored, but is co-managed by them and the Department of Labor and Workforce Development. Owners are a tremendous resource within states. We work with AIC to help facilitate a network of offices of New Americans from around the country, from 17 states. They share effective practices and policies, and there's a lot of good happening. And I know that the New Jersey Office of New America, we call them owners, is beginning to actively explore licensing reform in the healthcare arena. So keep them on your radar, and we'll come back to what some of those reforms could look like. In order to make inclusion work, we have to look at the barriers to economic mobility. A lot of them are systemic factors: a lack of effective workforce training, not enough specialized English language provision, limited recognition of credentials from abroad. There are mechanisms in place. They're not always effectively utilized. So in terms of state policy efforts, we have a lot of states, and we have a substantial track record working with colleagues across the country around reforming licensing laws and processes to streamline them, to make them more consistent, to remove discriminatory barriers. A number of states have established career readiness programs that draw on that workforce funding, those adult ed and English language funding, to gear programs specifically to internationally trained professionals. And a number of states have formed work groups or commissions to explore this issue writ large in their state, to marshal the research, to marshal the full spectrum of sectors and active and important constituencies within the state, to come up with recommendations to address the healthcare workforce shortages. In nursing, there are a lot of very simple ways to standardize and streamline around English language proficiency assessment, sometimes bizarrely applied or unnecessarily applied or unequally applied. Credential evaluation and recognition, despite the fact that this is a well-established practice, still remains problematic in many cases because of outdated rules. And states can look at licensing processes like endorsement and alternate pathways to support better tracking of individuals who might need a little bit of support, but can quickly be absorbed into the healthcare workforce that needs them so much. Washington, for example, introduced an IMG reform bill in 2021 that gave provisional licensing to qualified international medical graduates to gain the clinical experience they need to get full licensing. Just implemented this year. We look at other programs and the numbers around them. In the first year of implementation in Washington State, 50 individuals were provisionally licensed and were able to begin serving patients. We're eager to see the results and the impact assessed. That program has really just been in place for about a year. 3 other states have introduced legislation along similar lines. 12 other states have looked at, have introduced bills, have not yet passed. Sorry to say New Jersey's not yet on that list, but maybe someday. And the work groups and commissions has been a really remarkable development. We've seen a huge momentum around states creating these commissions. Illinois, Maine, Maryland, Massachusetts, Michigan, Vermont, Virginia, Washington have all done so. Michigan just released its task force report today, this morning. And I can tell you that there are a great deal of opportunities, a great deal of recommendations that touch on policy, that touch on programming, that touch on funding, that touch on licensing reform. And I think there's a lot of inspiration, a lot of momentum, great models that New Jersey can look to. I really look forward to seeing the discussion that we started today carry forward. For sure, we are eager to remain engaged, so that all of us in New Jersey can harness the talent of internationally trained healthcare workers and improve our communities, improve our systems, and together improve the lives of our fellow citizens here in New Jersey.
Thank you so much, Paul. That's great. And please check the webinar chat, because some of the things that Paul talked about are shown there so that the links are showing. And it's now my pleasure to introduce Dr. Nick Montalto, who has enormous experience in the area of immigration. We are honored to have him as the coordinator of the New Jersey Business Immigration Coalition. Nick?
Hi, everyone. Can you hear me?
Yes, we can.
Okay. Can you see me?
Don't worry about it. Not
I
yet.
don't know. I don't know why I don't have the image up here.
Just go ahead, Nick.
I'll just go ahead. Thank you, Catherine. And I just want to share with you a few parting thoughts before we conclude today's discussion. I want to thank Paul Feltman and Cecilia Esterline for sharing their insights with us, and I think pointing us in the right direction to achieve needed reform in this area, and both on the federal and state level. I also would like to thank everyone on the panel for giving us the benefit of your experience and expertise, and of course our keynote speaker, Mo Kantner, for providing such a rich context for this discussion. And thank you to our three moderators, Kyle Sullender, Catherine Kish, and Rachel Rosenthal. And finally, I'd like to give a shout out to the two sponsors today, Minor and Landis, the law firm, and St. Peter's Healthcare System. Without their support, it would be very hard for us to mount programs of this type. Finally, I just wanted to mention that there is a program, and I just found out about this yesterday. There is a program that will take place shortly, in fact, on Thursday of this week, by the Bipartisan Policy Center. That's an important think tank in Washington, and they're looking at this exact same subject. And their webinar will be on Thursday at 11 a.m. It's entitled Addressing the Direct Care Workforce Shortage in Healthcare. So if you're interested in participating in this webinar, you can go to the Bipartisan Policy Center website and click on their events page, and you'll see information about it. Finally, before we conclude today, I'd like to remind all of you that the New Jersey Business Immigration Coalition is seeking to attract new organizational and individual members who are committed to our goal of sensible, evidence-based, and bipartisan immigration reform. Since our formation a few years ago, we've enjoyed steady growth, and we're especially interested in recruiting healthcare organizations to our membership. If you want to learn more about the coalition, go to our website, njbusinessimigration.org. And by the way, there's no fee to join the coalition. Thank you all for participating in today's program. I hope you came away with a clear understanding that immigration is not always a problem, but very often it's the solution to a problem. Our coalition will do the best in the months ahead to advance this understanding in the area of healthcare and to champion some of the goals that have been proposed today. Thank you all for joining us.